One of the most common rhythms that I see in the hospital and in the office is a rhythm known as atrial fibrillation. Now, this is an abnormal rhythm that comes from the top part of the heart, and there's a lot of things regarding this rhythm that is very concerning. The first one is that some people don't feel good in this rhythm. They feel very uncomfortable. They can have palpitations, they can have chest pains. A lot of them even say, "Hey doc, something is wrong. Not exactly sure what it is, but I don't feel like myself." So we get an EKG and we find that they're in atrial fibrillation. Sometimes, sometimes they may have the symptoms and it happens sporadically. So that means that they're not getting it all the time. This is a fancy term meaning paroxysmal atrial fibrillation. Lack of better words, they go in and out of atrial fibrillation. So for those individuals, they may need a longer monitor to help capture it. Some of them may even have the Apple Watch that can capture it. They can use a cardiomobile that can capture it, or they can do a heart monitor that can go anywhere as little as 24 hours, but also upwards to 30 days. There are some individuals that we really need to make sure that they don't have it, and we can do a loop recorder, implantable loop recorder, where it actually gets implanted under the skin, and it can last anywhere from 2 to 3 years, sometimes even 3 to 4 years. The people who we really want that to, who we want to reserve that for, are people who have these unexplained strokes. But there's some other individuals that need it, especially if they're having issues with heart rhythms that we can't figure out, but it's happening enough. But also infrequently, like it's happening once every 6 or 7 months, and we just can't capture it with a 30-day monitor. So those individuals get a loop recorder. But yeah, atrial fibrillation, a lot of people don't feel comfortable with it. So, and that can also be due to the high heart rates. Some people can have heart rates as high as 170s, 180s. When that happens over time, it can lead to something known as cardiomyopathy, damage to the heart muscle, which can lead to the heart enlarging and the heart not squeezing as well. So we definitely want to capture it before that happens. The trick is sometimes people have atrial fibrillation and don't feel anything.
Sorry, could you say that again?
Sometimes people have atrial fibrillation and don't feel anything, and they can develop this cardiomyopathy over time. And the issue with that is the heart is very stubborn. The heart will try to fix itself, will squeeze stronger, will squeeze faster, hence the elevated heart rates, to try to see if it can do it on its own until it can't anymore. And when it can't anymore is when people start to develop those heart failure symptoms. They start having shortness of breath, weight gain, swelling, nocturnal dyspnea, paroxysmal nocturnal dyspnea, fancy word meaning that whenever they lay flat, they will start to become short of breath. So we don't want that to happen. So we monitor them closely, and then we start looking at treatments. If they've developed those heart failure-like symptoms, then of course you want to treat it with a diuretic to help remove the excess fluids. But with atrial fibrillation, our hope is to try to capture it before that happens. So how can we do it? Like I stated previously. What else about it? We've talked about people feel uncomfortable with it. They can have elevated heart rates, so we can bring it down in several different ways. We can bring it down with a rate controlling medication like metoprolol, carvedilol, or diltiazem. Those ones help to slow that heart rate down, in hopes that if we slow it down low enough, we can get them back into normal rhythm. There are some other therapies that we can use for people who have difficult to control atrial fibrillation, things like digoxin. Typically try to stay away from that. Typically, if you're going to initiate that, you want to watch them closely in the hospital, because you can have toxicities associated with it. And if the rate controlling medications are not working, meaning that it's slowing the heart rate down but there's still an atrial fibrillation, then you have to start to consider rhythm controlling medications, things like amiodarone, flecainide, ticosine, sotalol. They all work really well, but the issue is that they all do have their own side effect profile associated with it. So we have to be very careful in selecting the right individual for it. Some of them need stress tests, some of them will need labs, thyroid and liver function tests, some will need hospitalizations. Well, the medication works really well at low heart rates for some of them, so you need to watch them in the hospital to make sure that they don't develop any dangerous life-threatening rhythms at nighttime. Those typically are sotalol and Tickerson. You want to watch them for 6 doses. Those medications are typically twice a day, so 3-day hospitalization for it. So if that it works well, yay, we're happy. If it doesn't, then we have to consider following up with a specialized cardiologist known as an electrophysiologist to see what other options are available, things like ablations and sometimes even an ablation and a pacemaker. So that's one half of it. The other half is that people are at an increased risk of a stroke while in atrial fibrillation, especially if they have things like hypertension, diabetes, previous stroke. Age greater than 65, you get 1 point. Age greater than 75, you get another point. So if you have enough of them, especially if you have 2, 3, definitely 2, discussion, but want to be on blood thinners to prevent a stroke from happening. And no aspirin, no Plavix, no aspirin and Plavix will not prevent you from having a stroke. So things like warfarin, Eliquis, Xarelto, Pradaxa, all of those ones are the ones that we typically utilize when we're trying to treat the patient appropriately and helping them to prevent a stroke from happening. Some people are at high risk of being on these blood thinners. Some of them already have prior history of brain bleeds, GI bleeds, recurrent bleeds, significant falls, life-threatening falls. So you have to look at the risk and benefits of blood thinners. And if the risk far outweigh the benefits, then boom, we have to stop the blood thinners and hope that you don't have a stroke while off the blood thinners. But there is another option, and this is known as a left atrial appendage occlusion device, or a Watchman device. When someone has atrial fibrillation, that blood likes to fibrillate and it likes to collect in a certain section of the heart known as the left atrial appendage, and that is where it can break off and cause a stroke in the future. The Watchman device is a device that basically puts a cap or a cover over that area in preventing blood from ever coagulating in that section and causing a stroke. Works really well. Do need to have subsequent transesophageal echocardiograms to make sure that it is well seated and it hasn't moved and we don't see any blood communication in that area. So for people who are at high risk of bleeding or have high risk careers that do not want to be on blood thinners and have enough risk factors, then the Watchman device is a great option for them. Now the last thing, the one that needs to be talked about a lot, sometimes it's not talked about enough, is risk factors for atrial fibrillation. I think 2 of the biggest ones are obesity, probably is number 1, and then number 2 is obstructive sleep apnea. I have found that a lot of times when people have their sleep apnea treated, that they don't have any subsequent further episodes of atrial fibrillation. I have a personal family friend that was significantly overweight, had significant sleep apnea, got his sleep apnea treated, lost significant weight, and to my knowledge has not had any further bouts of atrial fibrillation exacerbations, and doesn't have a lot of risk factors, so likely doesn't need to be on blood thinners. So looking at the risk factors for it, especially obesity and sleep apnea, is one of the things that I recommend for a lot of my patients. In fact, one of the biggest things that you can do to help prevent future exacerbations of atrial fibrillation is weight loss. How much? Around 10% weight loss. I find that people who lose that 10% of weight, it doesn't just stop there. Once they start losing that weight, they start to feel better and they start to incorporate better lifestyle choices to prevent future exacerbations. They start to eat appropriately. They start to watch how much fluid intake, if they do have a component of heart failure. They start to make appropriate food choices, lifestyle choices, salt intake, Foods that can trigger palpitations, atrial fibrillations: excess caffeine, stress, getting enough sleep, and following up with your medical provider, because a lot of times people develop these rhythms because it is from something else. That something else can be hormones that are off, it can be thyroid, it can be testosterone, estrogen levels are off. Just making sure that you're following up and treating underlying risk factors and potential triggers for atrial fibrillation. It's a difficult process, but I like atrial fibrillation because one treatment is not the same for each individual, and you just have to sit down and talk to them and talk about the different ways that you can provide care for them, but also discussing the risk factors that are associated with it. If you guys battle atrial fibrillation or have any further questions, leave it in the comments and I'll be happy to answer.